Hello doctors. Today we are going to study about the topic uterine fibroid, which is one of the most common benign tumors in women of the reproductive age group. So we'll understand the definition, types, and what are the clinical features of this condition, and what are the investigations you can do, and how you can manage it in both IPD versus the OPD approaches. So let's start with the topic. Uterine fibroid is also called as leiomyoma. It is a benign smooth muscle tumor arising from the myometrium of the uterus. It is a hormone dependent, mainly on the estrogen and progesterone. So they are usually multiple, well circumscribed, firm masses, as you can see in the picture below there. Though it is benign, they can cause significant morbidity due to pressure symptoms like menorrhagia or infertility. So this is what about the uterine fibroid. So it is also called as a leiomyoma. It is kind of a benign smooth muscle tumor of the uterus, which is arising from the myometrium of the uterus. Now let's talk about the epidemiology. So these are most common pelvic tumors in women of the reproductive age. So the peak between from the 30 to 40 years of age, and rarely it is seen before the puberty, and they regress after the menopause, so which again shows their hormonal dependency. So they are more common in nulliparous women, and there is often a genetic predisposition, or meaning a family history, which increases the risk. So this is what the epidemiology of the uterine fibroid. Following with the etiopathogenesis. So etiopathogenesis, let us understand why fibroids develop. They are hormone dependent, so estrogen and progesterone promote the growth. And they are like genetic mutation. There can be genetic mutation like MED12 gene mutations, which are frequently found, and there are familial tendency also. Next is the growth factors. So, growth factors such as TGF, beta, IGF, EGF, which will stimulate the smooth muscle proliferation. And because the uterus has rich vascular stroma, these tumors get the blood supply and continue the growth until the menopause. So, due to the risk vascular stroma in the uterus, there can be more blood supply, vascular supply, and it can lead and it can continue till the menopause age. So that is the etiopathogenesis. Now we'll see about the types of fibroids. So fibroids, we are classifying this based on their location in the uterus. So there are different types like intramural, submucous, subserous, cervical, intraligamentary, and all. So we'll see one by one. Intramural, it is like within the uterine wall, which is like a most common type. And next is the submucous. Submucous is like they will bulge into the uterine cavity, causing heavy bleeding and infertility. Third is the subserous. So subserous is like the thing which is projecting outward. It may become pedunculated and can cause pressure symptoms. So these things you can see in this picture there, how it is presented. And fourth is the cervical. Cervical, how it is, it arises from the cervix, and sometimes it may obstruct the labor also. So that is a cervical type of fibroid. And the last one is intraligamentary. Intraligamentary, it is like between the layers of the broad ligament. It grow between the layers of the broad ligament. uh, so so this is the picture there. You can visualize how the site affects the symptoms and all. So you can go through it, the picture below, the types of fibroids, so the pedunculated subseral fibroid, intramural subseral fibroid, and submucous fibroid and all. You can see how the presentation is according to the locations. Next, we'll move forward with the pathological features or pathological things we'll be seeing in the uterine fibroid condition. So grossly, the fibroids, which appears as a firm white, gray, old masses, and they are surrounded by a pseudo capsule, and there can be degenerative changes also, which are very common in this condition, like hyaline degeneration, which is the most common and most frequent. Next is cystic and red degeneration, which occurs especially during the pregnancy due to venous thrombosis and infarction. And rarely you also may see calcification also, or you can say sarcomatous transformation, which is malignant. So this is the pathological features you will see in the uterine fibroids. One is hyaline degeneration, then there is cystic and red degeneration red regeneration will be present in the pregnancy, and then rarely you might see calcification and sarcomatous transformation also. So these are the basic pathological features you will be seeing in the uterine fibroid condition. So next we'll see about the clinical features. So what are the clinical features will be presented in the patient who is having a uterine fibroid? So the presentation depends on the size, number, and location. So the most common symptom is menorrhagia. There will be heavy prolonged menstrual bleeding, and there may be metorrhagia also. There will be irregular bleeding. And next is dysmenorrhea. Sometimes due to the uterine congestion or distortion, there will be dysmenorrhea. Next is the pressure symptoms. Pressure symptoms like there will be frequency of urine and constipation and all. Next, fifth one is infertility or recurrent abortions or recurrent pregnancy loss. It is mostly seen in the submucous type of uterine fibroid. And the last, and sometimes the last one is sometimes a lump in the abdomen or like heaviness can be seen. And there are other risk factors also, like high levels of estrogen and progesterone, and in the especially in the nulliparous individuals there are risk factors. And there can be symptoms, abdominal pelvic pain, low back pain, constipation, infertility and all. So like this is the things, so the clinical presentation we'll be seeing in the patient. Moving on to the signs. So, what are the signs we'll be seeing in the patient, like when on examinations and all? So, on examination, the like while doing the examination of uterine fibroid, the uterus you will be see will be enlarged, and it will be firm, irregular, and mobile also. Mobile mass, which will be like unless it is adherent, you can see this firm, enlarged, irregular thing, and it is usually separate from the ovaries, so which will helps us to differentiate it from the ovarian masses. And the size is often described in terms of pregnancy weeks, for example 12-week or 16-week size fibroid uterus. So that is the the thing signs you will be able to see. Sometimes there can be chances, misconception like pregnancy and all. So that is the thing, so you should be able to know the size of this thing. And the pregnancy weeks, so for example like 12-week, as I mentioned, 12-week or 16-week size fibroid uterus also can be seen. So uterus will be enlarged. So these are the common important thing you have to be keeping in mind, so that you can differentiate from the any other possible causes. So that is the signs we have discussed now. Coming to the complications. So complications, fibroids can lead to several kind of complications. Like first one is degeneration, which can be red, cystic, hyaline, which we have already discussed in the previous slide. Second is the torsion, especially if it is like a pedunculated fibroid. Then third is infection or necrosis within the tumor. And next one is infertility and miscarriage or repeated abortions or recurrent abortions, preterm labor. So these things due to the distortion of the cavity. And last one is rarely we'll be seeing malignant transformation into leiomyosarcoma, which will be rare, which is less than 1%. So even though uterine fibroid is a benign condition, they need a careful monitoring. So that is the things about the complications of uterine fibroid. Next, we'll see about the investigations. So, investigations for like diagnosis, we have to go through certain things. First one is ultrasound pelvis. It is the first line and the most reliable investigation you can do in such conditions. Next is MRI. MRI is done for mapping the fibroids and before surgery or embolization. And for pre-surgical planning and all, you can do MRI. CBC, which will help us to check anemia due to menorrhage or heavy bleeding and all. Next is hysteroscopy or saline sonography to rule out if there is any submucous fibroids. Then last thing you can do is endometrial biopsy. If the like it is needed only if abnormal bleeding occurs in women above 40 years of age to rule out any kind of malignancy. So this is what the investigations you have to go through it to diagnose the condition. Next is the differential diagnosis. Differential diagnosis, like always we have to differentiate fibroids from certain things. One is adenomyosis. So adenomyosis, the in this case the uterus will be bulky and tender. And ovarian cyst or tumor, it is separate from the uterus, different mobility. Pregnancy, especially like positive, especially missed abortion, pregnancy positive, the urine test will be positive. So but you have to be knowing this differential diagnosis. And the last one is uterine sarcoma. Uterine sarcoma, there will be rapid growth and the post menopausal bleeding. So these are the differential diagnoses you should be aware of while treating the uterine fibroid condition. Next, moving on to the management part. So how we have to do the management. So management depends on certain criteria. It depends on the size, site and number of the fibroids present. Next is the age of the patient and the age of the patient as well as her desire to future fertility. Next is the severity of symptoms. So and if there is any associated anemia or pressure effects and all, so you have to rule out all these things while taking the history of the patient when about the clinical features and what are the diagnostic techniques you are using, investigations things. So from that itself you will be knowing how to do the how to plan the treatment. So management of the condition, it depends on all these things: size, site and number of fibroids, age of the patient and the fertility wishes. Next is severity of symptom, how severe the symptoms are, and associated anemia or any kind of pressure effects. So treatment can be either medical or surgical depending on the case. So that is a management overview. So now we'll see how we have to manage in the the patient in the outpatient basis and the IPD, that is inpatient basis. So in OPD, the outpatient management, we mainly manage the mild or the moderate cases. Observation, we have to do the small asymptomatic fibroids just need a follow up. Medical therapy, you can go for tranexamic acids for to help to reduce the bleeding, NSAIDs for pain relief, like in case of dysmenorrhea and all. Then you can go for hormonal therapy, combined OCPs, progesterone only therapy, or GnRH analogs to reduce the size temporarily. You can do that. Next is always treat anemia if it is associated with anemia with iron supplementation. And last one, you can do advise ultrasound every 6 months for monitoring the condition. So these are the things you can do to the patient in the OPD basis. Moving on to the IPD management or the inpatient management, or how we can do in surgically. So when fibroids are large, which is greater than 12 to 14 week size, which is symptomatic or not responding to any kind of medications, uh, then severe bleeding not controlled medically, and if there is pressure symptoms, infertility due to fibroids, in these conditions, or if there is a rapid growth, these conditions we can go for a surgical option. So surgical options are considered under these conditions or indications. So procedures include myomectomy, where there is we'll remove the fibroid, preserving the uterus for fertility. Second is hysterectomy. Hysterectomy is a definitive treatment for women who have completed the childbearing, so you can go for that. Third is uterine artery embolization, UAE, which will be doing a blockaging of the blood supply to the fibroid and shrinking it. So that's the method. Next is the MRI guided focused ultrasound, FUS. So it is a non-invasive option. So these are the procedures you can go do in surgical management if the patient is not responding or the condition is not responding with the medical therapy. So this is how you have to do the management in OPD basis versus the IPD basis. Moving on to the fibroid in pregnancy. So fibroid in pregnancy, as we have mentioned, fibroid in pregnancy cause like during pregnancy can complicate many kind of things. They may undergo red regeneration, causing pain and fever, and they can cause abortion, preterm labor, malpresentation, or obstructed labor. In most cases, we manage conservatively with the rest and analgesics. Then myomectomy during pregnancy is avoided unless it is pedunculated fibroid causing torsion. So this is the things which we'll be seeing in the fibroid in pregnancy. So what are the conditions, what are the post-operative care we can do after the surgery? So after surgery, we must monitor for bleeding, infection, and ensure good pain control. Correct any kind of anemia and maintain the hormonal balance. Advise avoidance of heavy activity for a few weeks, and also ask them, advise them for a long term follow up, which is very essential because fibroids have the tendency to reoccur. So recurrence, to avoid recurrence of fibroids, you can advise for a long term follow up, especially after the myomectomy procedure. Now talking about the prognosis. The prognosis is generally very good since these are the benign and the slow growing thing. However, there is, as I have mentioned, the recurrence is possible after any conservative surgery. And malignant transformation is extremely rare, but most patients do well with the appropriate management. So that is the prognosis of this condition. So to summarize our today's session, as we have so we'll just brief of uterine fibroid is most common benign tumor of uterus. Symptoms depend on the size and location, and the diagnosis is mainly clinical and it is confirmed by the ultrasound and other types of investigations. Management, when you're coming, it should be individualized, medical or either surgical, depending on the fertility wishes. So always ask the patient regarding their wishes for fertility, and it should be individualized, and it should be age matters. So in these conditions, age is also a matter, fertility is also a matter. So that is a two important thing. So that's it for today's session. So I hope you got a clear idea of the topic uterine fibroid. Thank you so much for patient listening. Have a nice day.